one of the most common tests is called UPSIT, University of Pennsylvania Smell Identification Test. It's a test that has 40 standard smells that are absorbed or impregnated into cards in different sets. And there are sets that smells that we have been checking, like banana and orange and mint. And you have to score the patient on how many smells they can identify. So that's an identification test. And then there is a smell threshold test, also by University of Pennsylvania. Okay, so in addition to separating the smell, which is a cortical phenomena, cortical feature, but needs some smell assessment, you also need to see at what threshold the patient can detect the smell. So those are serially diluted solutions that have smell strength or odor strength, universal odor, pungent odor, that gradually drops in a logarithmic scale. So it's serial dilution. So 1 in 1, then 1 in 2, 1 in 4, 1 in 8, 1 in 16, 1 in 32, and so on and so forth. And then you can detect where the patient is in terms of threshold. Now there is threshold which varies from smell to smell. We are more acute, or we are more acutely aware of sharp and pungent smell, and less so for sweeter smell. So there is a more universal smell threshold battery. Again, I think 5 or 8 different types of odor in a graded intensity where you can detect where they are on their smell. Okay. Let's go to number 2. Cranial number 2.
I just want to make a couple comments. The first cranial nerve is variable depending on whether you're in a dry area, whether you're having a runny nose, whether you have a cold, whether you've been exposed to a smell for a long period of time, a sulfurous smell. If it's in the room and some people walk in, they're going to say, boy, there's a bad smell in here, and we've all become used to it. So our smeller is very good at identifying new things, but it gets saturated and you don't pay attention to it anymore. It's like anything. If you have something resting on your skin, you'll feel it for a while and then you won't notice it until somebody takes it away. Well, there was something there.
What is the most common cause of hyposmia?
Chronic rhinosinusitis.
Trauma.
Neurological.
Trauma.
Neurological condition.
Parkinson's.
No.
Alzheimer's.
Alzheimer's. So most common cause is Alzheimer's, which is the most common neurodegenerative disorder, but it's much more prevalent in Parkinson's. Some people say it's almost 100%, but there is debate. Most studies between 50 to 80% of Parkinson's patients who have smell loss, but it's 30 to 50% in Alzheimer's.
So now that means that everybody has a maybe a 50 to 60 to 70% chance. If you live long enough, you're going to have some dementia, and you'll probably lose your sense of smell too.
What is the most common cause of hyperosmia?
Temporal lobe fascia.
Temporal seizure.
Most common.
Why do you come up with these questions? Just sort of think of these on the way home.
Migraine is common, but not the most common. It might be most common in a neurology clinic, but it's not overall most common. Schizophrenia and psychosis. So bipolar disorder in manic state, schizophrenic, manic, psychotic patients, they have hyperosmia. But in neurology clinic, most common is migraines or headaches. Most headaches have some hyperosmia, but migraines are most common or most acute, severe smell. So number 2, thoughts, tips, tricks, things that we've not checked so far. Come on, senior residents, you're full of information. Share with your junior residents.
So we observe the pupils first before light, shining the lights, then after the shining the lights for light reflex, and also for direct and consensual light reflex.
Yeah, we discussed all of that. So what we have not discussed so far, this is about that. What is the acceptable asymmetry limit between the two pupil sizes? 1 millimeter. So up to 1 millimeter is acceptable difference between the two pupils. Okay. What is the name of tremor of the pupillary margin? Hippus. Hippus is the slight margin. It's best visualized by ophthalmoscope, ranged up to 20 times magnification. So you move it up, and that's actually one of the trick. Probably Dr. Kitab will teach you that ophthalmoscope is not only important for looking at the back of the eye, it's also very useful looking at the front chamber of the eye. So one of the best ways to pick up, for example, the ring from Wilson's disease is by using ophthalmoscope. So a mild copper deposition might cause brown discoloration that is not visible by naked eye, but if you amplify 15 to 20 times, and that's why it has that amplification on the ophthalmoscope, and then look at the limbus, the edge of the cornea, you could pick up the Kaiser-Fleischer ring much more sensitively. So that was part of my routine exam when I was a resident. I've gotten lazy now. In looking at any patient's eye ophthalmoscope, that's part of it.
And then the other point I want to make on this is if on the ward you happen to have a Wilson's case, everybody with the patient's permission should be able to come in and see, you know, which level of the cornea this is, whose membrane it is.
Yes, mention.
Yeah, so that you have to learn those kind of things, but if you see a patient with, on the wards, there's all sorts of weird and wonderful things. So if there's somebody there that has Wilson's, don't miss the opportunity, because then you can brag to your friends, oh, I've seen 3 Wilsons. But you didn't take care of any of them, you just, pictures online don't help. But, you know, anything you can do to see what it's supposed to look like is going to be a big plus.
Anybody with eye complaint, especially blindness in a consult in ER, you must feel for their eyeball firmness or indirect way of looking for increased intraocular pressure, which should never be missed. It's criminal. You can have a lawsuit if you missed. It's an ophthalmological surgical emergency. It must be drained right away.
So the patient will complain of intense pain. And the way to do this is what's called ballottement. So close your eyes. So I just put my thumbs right over both eyes, and you can try it on yourself or other people. You can, there's a little bit of a give back and forth, but with a really hard eye, with really increased intraocular pressure, it's not going to be as spongy. You can't push in quite as much. And that's the side that's going to have, let's say, an acute glaucoma problem. The same thing is true for an orbital tumor. That is not going to be something you can push back a little bit. Now, you don't usually go around, you got to close the eyes to do this. But you have to get used to that. And it's another trick that you have that you can come to a diagnosis or a suspicion or rule something out a little bit anyways, not 100%. But you got to use your head and think outside the box. How else can I come at something like this?
Okay, our senses can be trained to be very sensitive to pick up even minor abnormalities, but you have to examine a lot of patients, normal and abnormal, before you reach that level of sensitivity. The more you examine, even normals, and especially normals, the more you become tuned to picking up minor abnormalities that seems impossible to pick. You just do enough, you will start picking it up. Very good. Let's go to, there's a lot about 2, but I'll leave it for ophthalmology. 3, 4,
Oh, the
6.
one thing I want to say, when you try to do a fundoscopic, here's a trick that I use, and you'll get other tricks. Put the light on the lowest setting so it's not very bright. Get a dark room, and what I first do if I'm trying to find the disc is I have the patient looking this way, so I go to a very insensitive part of the retina, way off to the side. And I'm just looking at a very peripheral part of the retina, and I use the lenses to get, so I can see the small vein or artery at that point clearly. You got it? And then I follow the blood vessels like it's a little river starting in the mountain, getting bigger and bigger. Both the arteries and the veins will do this. And you come to where they all converge, and that's a good place to look around because that's your blind spot. So then you can look at that point and use a brighter light if you need to, but you've already gotten the patient accustomed, and they've got to remember to keep on looking at some place, even if you're in the way, And if they can do that, you can get a really good look at the vessels, and you get near the disc, you can do all the things you want to look for the disc. There's a lot of clues on what's early optic neuritis, what's early swelling of the disc. And when you look for venous pulses, sometimes you can either put pressure on the eye to make it come and go and make sure they're not really way off. Anyway, and I actually had a pet dog at the time, and I got so the dog would hold still and I could do a fundoscopic on the dog. So if you can do that on our wild dog, you can do it on anybody. So just practice, practice, practice.
Okay. 3, 4, and 6. Senior residents, tips, tricks, things you want to share?
I didn't go over head moves the way the weak eye can't. This was another one of those, Dr. Henderson, he would have a meeting with us every Wednesday morning. He was really recruiting for ophthalmology. But anyway, yeah, if I can't use my right lateral rectus, then I don't want to be looking at you like this, do I? Because then I got to use my right lateral rectus. So I will do this. So I don't use that. I'm using my medial rectus on that eye. So what that means is that I'm going to turn this way if I can't move my eye this way. So it's true of the right lateral rectus and the left medial rectus, right? So you can just see by the patient's head turn, they're eliminating the double vision. They say, well, what happens if I go like this? And then they say, oh, I see two of you. So they don't know they're doing it that way, but that's a clue. The same thing is true for head tilts. If they have a head tilt like this, and you go, what happens if I do this, and they see two, then you know it's one of those muscles, those yoked muscles that they're using so they don't see double. Do you understand where we're coming from on this? So if you go back logically, there is a reason they're doing this, is because if they don't, they see two of you. And if they come in like this, it could be torticollis. It could be also that they got double vision. And if they're noticing two images, it's not something that just that they were born with, right? Because you've seen people that you can't tell who they're looking at, you or the guy over here, because they're only looking at one. You can, when you're doing a fundoscopic, you should have both eyes open. You should be able to ignore one eye while you're doing a fundoscopic. Not everybody can, but the idea is, if you're still seeing two images, it's not something you were born with, right? Okay.
Good. 3, 4, 6. Tips, tricks. You don't have enough senior residents. Why are they?
Cover and cover tests.
Oh, the cover and uncover test.
The
Yeah.
flying off, or what? They have excuse from the conferences now?
A hand and the back.
You two are just holding the fort for everybody in the senior group?
So what does the cover uncover test tell you? You know the cover uncover test?
For hidden strabismus.
Right. I mean, when you see somebody in a PET scan or an MRI scan or a CAT scan, their eyes are not looking parallel some of the time. They may be like this a little bit or like this a little bit. And it just, what's the tendency? There are some people that, you know what the difference is between aphoria and atropia? Euphoria is a good thing. So aphoria is something that if you cover an eye, it will go where it wants to, but when you uncover it, it comes back. That's only a little bit of a deviation. And with both eyes open, they're looking at what they want to, and they don't notice a double vision. These people, if it's a big phoria, at the end of the day, if they're really tired, they may not be able to hold it, and they'll have, end of the day, not just with myasthenia, because myasthenics get worse the more they use their eyes, and the muscle that gets weak, it gets weaker. But some people have aphoria that turns into atropia. Atropia is they're looking at you with one eye, okay? And you say, well, what happens if I cover this eye? Then they're looking at you this way. When you uncover this eye, it's usually way out here. So there's a normal, and again, some of us are focused here, some of us are focused here when we have our eyes closed. Everybody's a little different, but we should be able to focus both eyes on any image. Now, when you ask somebody to look at my finger as I come in, they'll be reach a certain point, and then one eye will go off, and they'll follow you with one eye. So there's always some, I mean, you really can't, well, I guess maybe you can if you're really good at it, but it doesn't feel right. But that's the difference between phoria and tropia. And if you go like this and you uncover and you see that eye coming back this way, you know it's an exo if it's this way. If it's this way, it's esophoria. If it's this way, it's hyperphoria. And if it's this way, it's a hypophoria. Up, down, hyper, hypo, exo, eso. And then if it's a tropia, it's the same thing. This is an exotropia. This is an esotropia, right? Hypertropia, hypotropia. So now you can talk in Greek like ophthalmologists.
Okay, anybody else have any tips, tricks for the 3rd, 4th, 6th exam?
Sometimes when evaluating for diplopia, it's not as obvious like on some of the pictures we've been seeing. It's obviously a third nerve palsy when the eye is down and out, but sometimes it's a lot more subtle than that. You can't exactly, it can be just a very subtle weakness. Sometimes a helpful thing to do is to do the H pattern and try and delineate when is the double vision the worst when they're looking, what direction. And it helps if you have a red lens, but
Yes.
like where are the pictures in relation to each other? Are they on top of each other? Are they to the side or diagonal? And that'll help you figure out which nerve, if any, is involved in making the diplopia.
How does that red lens help?
The red lens just helps you determine which eye, like which image is which eye. So like if you have the red lens over the right eye and the red picture is on top, it lets you know that it's the right eye that's on top.
So it changes the tint between the two pictures or two.
Yeah.
Right.
So you put one eye.
And
Do you-
remember that the weak eye is, if the image is higher, the eye is lower. It's backwards, right?
Right.
That's, because if I'm not looking all the way over here with this eye, then this one is hitting a real purple part, so the eye that doesn't come all the way over sees the image coming way over here, and this one sees it directly straight ahead.
Do you examine both eyes together or separately?
I start together, just so that we can elicit the double vision. And if you're going to do them separate, it's always, when looking left and right, you should always be able to bury the sclera, like you should always get your iris, the color part of your eye beyond the fissure, and if not, then you know that that's a weakness.
So we control of eye movements for both eyes together, what we call conjugate gaze. And individual eye movement, which is creating nerves and muscles that we talk about, is different in the brain. So you have to remember that you may not get same weakness or same findings if you examine them only separately or only together. So both ways have to be done if there is an eye weakness. If there's a complaint of double vision, blurred vision, you expect an eye weakness, or you're really looking hard, then you have to look them separately. Talking about esotropias and phorias, red lens, what's a concomitant esophoria, what's a non-concomitant esophoria, or concomitant diplopia and non-concomitant diplopia. Dr. Young, Bang.
Concomitant is the degree of deviation is the same.
That's true. So concomitant diplopia, like Dr. Bang said, that's why she's always quiet, she already knows everything, is that the distance between the two images, true and false image, remains the same regardless of which direction they're looking. So if you move the finger and they see two fingers and they stay the same apart, then that's a concomitant diplopia, which is usually monocular diplopia, and it's usually a defect in the cornea, but most often due to lens. When the lens is going through cataract and it has partial cataract, they start having refraction errors and they have concomitant diplopias. A non-concomitant diplopia is a true binocular diplopia where the degree of separation varies based on which direction they're looking. So if you look towards the good eye muscle, like lateral rectus palsy, like Dr. Bertoni is saying, and you look towards the left, they fuse together to one image. and then you look towards the right, and the right eye cannot abduct, and then the image starts separating it out more. Same is true for other situations. This was just one example. So that's important to ask what's happening to the images, and that's where red lens really help. Are they closing, separating, and in which direction? And that will be useful to make that diagnosis.
I want to ask about, have you ever seen voluntary nystagmus? Sometimes in a program, there's one guy that's able to, or one woman, what happens, there's two ways of telling that it's voluntary. What happens is people will say, I've got trouble with my eyes, and their eyes go like this and they jiggle like crazy. And then it quits. And it happens so some people can do this by converging their eyes together. They can make a wiggling, but there's two clues. Can you guys guess? If it's a voluntary convergence of the eyes, what's going to happen to the pupil?
Constrict.
Okay, so the clue number one is, if it's voluntary, the pupils get small when they're adducting their eyes. The other clue is they can't keep doing it. They do it for a few seconds and then it relaxes and you see the pupils come back to normal. So that's voluntary, and you can make them stop it. But sometimes you can get a little bit of head trauma and then you get a tethered eye muscle. Have you ever heard of that? Like the lateral rectus can actually be pinched by there's a little separation here if there's a head trauma, and then if you happen to have your lateral rectus there, it traps it, so that when you're looking this way, it looks like you got a medial rectus palsy, and how do you tell if that's actually the case or not, if you're an ophthalmologist? What they do is they anesthetize part of the sclera, they grab it with forceps and try to pull it over, and if they can't, then so what they can do is they can go in and, I guess, push these bones apart and then free it up. But that's not something you'd want to do at home, unless it hurts a little bit.
All right, let's go to 5. All right, any tips, tricks there for 5?
So 5 is mostly tested only for the sensory part, but it has also a motor part, which is involved the masseter muscles and other reflexive part, which is the jaw reflex.
Good, very good. Jaw jerk is typically not present, so it's usually abnormal whenever it's elicited. I think, what's the strongest muscle that opens the jaw?
Lateral tympanoid.
No, remember, these are always trick questions. They never have a straight answer. It's gravity.
Gravity.
So the most important reason to open the jaw is gravity. There are a weak opening muscle. That's why we don't need strong muscles to open the jaw. The weak one are digastric. Okay, digastric, which is right here. Digastric muscle, very thin and small muscle, and partial function of lateral pterygoids. So lateral pterygoids basically move the jaw side to side, to opposite side, but they also partially open the jaw. So that's useful for jaw opening dystonia and in doing Botox injections for that. But the point is that the jaw muscle weakness, masseter and temporal, is very easy to pick up if they have a jaw drop, and that's why it's not commonly examined. It's more commonly found abnormal in muscle diseases. Can you think of any where the jaw muscles would be abnormal?
ALS.
ALS has a common involvement of fasciculation on masseter and temporalis. Anything else? No, not really. Usually they may complain of chewing weakness, but you don't see anything.
Guillain-Barré syndrome?
Which one?
Guillain-Barré syndrome?
No. So Guillain-Barré is a ascending paralysis, starts from toes and goes up gradually. What is the descending paralysis? Botulism. So that's where the jaw and face weakness comes on first. You also see it in a lot of muscular dystrophies. Having atrophy of the temporalis and masseter muscle is common in lot of, for example, first thing you should think of is MD, muscular dystrophy, type 2. The other things it will be
Myotonic dystrophy will do it.
myotonic dystrophy, MD, and then you should also think about muscle overactivity of the jaw. So bruxism or jaw dystonia is very common. Tetany can cause jaw locking, or trismus is what it's called. Good. Let's go to 7. Any tips and tricks there?
What if they say sounds are louder on the side of the weakness?
Hyperacusia.
What's the cause of that?
Facial
Step-
Which one?
Stapedius.
Stapedius? Because I think that's the smallest muscle in the body.
Yeah.
And, if people will tell you, sounds are really loud on that side, then you can see where in the 7th nerve there's the effect. You can look at 7 and 8 are affected together. It could be in the auditory canal, internal auditory canal, right?
Very good. What do you think, Dr. Bang, about the differences between upper and lower motor paralysis of face?
Upper motor means it's coming from the brain, so it does not affect the upper part of the brain.
Okay, that was the easy answer. Now tell us the hard answer, more detailed answer. How would you differentiate the upper motor from lower motor brain? And when do you have challenges?
Everybody is true.
Where is the demarcation line between upper face and lower face, which is not involved and involved in upper motor versus lower motor weakness? You said the upper face is spared in an upper motor region, but not in a lower motor region, right?
Right.
So what is the line of demarcation between upper face and lower face?
Facial muscles.
On the face when you're examining.
Oh, that's kind of
Is it the external
Yeah.
canthus? Is it lower?
Oh,
Where do
gotcha.
you- Yeah, is it above the nose, below the nose? Where is it?
Remember, my questions are always trick questions. I don't know the answer. So the point is that there is no line of demarcation. The involvement of the upper muscles of the face and lower face is graded. So it's gradually disappear. So you have the complete paralysis of the lower face. You have a mild or moderate weakness in the middle face, and then forehead should be completely normal in upper motor neuron region where the upper side is spared. So it's a graded weakness. The actual amount of control the other side has for the upper face varies from person to person. So you may still see some mild weakness on the upper face in some people, and it's okay. You can't just assume it's a lower motor paralysis, okay? The other thing to remember is that the bilateral control is not because of bilateral supply to the cranial nerve 7 nucleus from the other side of the brain. It's a complex through an interneuron network, but let's just leave it at that. Okay?
So
But
what-
practically speaking, remember that mild weakness of upper face can be seen in an upper motor neuron lesion. It may not be completely normal. Okay?
Okay, yeah, a good point to remember on this is I try to do both when I examine for facial movement, like this. If I'm worried about somebody being a little weak on one side, I'll tell a joke. And they'll make a face just like that. Okay, so we had one woman when I was at Creighton, I was over there for many years, who was a nurse, and she came in looking like this. So it takes muscles to make that expression. And she had 3 little children, and when her husband would come to visit, which wasn't often enough, he'd be in the corner, body language as he's leaning way away from his wife. There was palpable tension between the two. The kids were jumping up and down on her bed, and she was sitting there like this. And I couldn't get any movement of either side of the face. There are some important causes of bilateral facial weakness that you have to know about. But I couldn't do anything. So if you do a cornea response, or you sneak up, or watch somebody sleep, and they start to smile, you know how little babies are when they're in REM sleep, or you could sneak up and tickle her nose or something. I didn't do that, but you could just see her do this, and then you know there is facial movement, right? Ed Schima, who used to be one of our docs over at Creighton, was really good. And I said, Ed, I want you to look at this lady. I'm sure it's bogus. Because I said that this was a voluntary facial movement that she was doing, this expression. And she got so mad that she wrote a letter to the CEO of the hospital and tried to get me in hot water. So Ed Scheimer walked in the room, just looked at her or something, asked her how life was going, and then made a joke, and she smiled on both sides, and he just walked out. So there are some things that are incompatible with bilateral weakness, and if you know how to do it, you know, you can prove, I mean, that's a proof. If the face moves with voluntary movement, it's not a lower motor neuron problem, right?
All right. If you have seventh nerve involvement with reactivation of herpes zoster, where will you see the rash?
External ocular canal.
So in the lower medial 1/3 of the external auricular canal, this small area supplied by the seventh nerve as a skin sensory area. And what's the name of that syndrome? Which type?
2.
Type 3. What are the 4 Ramsay syndromes? Type 1, type 2, type 3, type 4. All right, that's your homework. Fine, now let's take a 5-minute break.
I'd like
and
to
let's
say
continue.
something about that. Why does Dr. Fayyad and Deasing and the stroke team want to know if there's herpes zoster oticus? Because it can affect the middle cerebral artery, and you can get a hemiparasis.